Spotlight series on health economics. For those of you who are used to seeing Agostina's face presenting these, my name's Sarah Ely and I'm the Senior Project Officer Capacity Building at Health Translation SA. I'll be looking after Agostina's role while she's on maternity leave, and that includes the Spotlight series. Before we get started, I'd like to acknowledge the Kaurna people as the traditional custodians of the Adelaide region. We recognise the Kaurna people's cultural, spiritual, physical and emotional connection with their land. We honour and pay our respects to Kaurna elders, both past and present, and all generations of Kaurna people now and into the future. So I'm here in Adelaide Plains, but there may be people who are in other parts of the country, so feel free to type in the chat if you'd like to let us know where you're from. So what is the Spotlight series? It was an initiative launched by HTSA in November 2021 as a way to build knowledge and capacity in a range of essential research skills and topics through month-long focus promotion, education and resource sharing. So we've held quite a few of these now. We've had one on implementation science, research impact, community engagement, the MRFF, and then we've got this one on health economics. And these previous recordings and all the resources can be accessed via the HTSA website. So HTSA, our purpose is to accelerate the translation of research findings into healthcare practice and policy and increase whole of system research translation capacity to improve the health of South Australians. We do that through a range of ways, but we work with our partners and stakeholders and as an independent catalyst and broker to mobilise collaborations that address major health system challenges. So today's webinar is like I said, the last in the health economics series. It's on research impact and economic evaluations. And we have three great speakers today. Dr. Shanthi Ramanathan from Hunter Medical Research Institute, Associate Professor Courtney Ryder from Flinders University, and Camille Schubert from the University of Adelaide. So what we'll do is we'll have our three presenters present and we'll hold back questions till the end of the session. But if you have any questions or comments you'd like to make throughout, please feel free to use the chat. So I'm just going to introduce Dr. Shanthi Ramanathan. So she's our first presenter. Shanthi is a leading research impact and research impact assessment practitioner in Australia. She's the research impact lead at the Hunter Medical Research Institute and a conjoint academic with the University of Newcastle's College of Health, Medicine and Wellbeing. She's passionate about building impact and translation literacy and capability amongst researchers. So I'm just going to stop sharing my screen and Shanthi, I'll hand over to you for our first session. And if you could please share your screen. Thank you.
Thank you very much for that introduction, Sarah. I'm just going to quickly share my screen and it takes a couple of minutes, but let me know when it's got there. Have all of you got visual of my screen? But I'll start by saying thank you very much for this invitation. I feel a little bit like an imposter because I really probably should have been in the sessions around the impact assessment, but the tool that we use has got an economics component. So that's the bit that I'm going to try and focus on today. Is this going to full screen for all of you now? Excellent. I wanted to actually just add as well my acknowledgements of country to the traditional custodians on the land on which I actually work, which is the Awabakal and the Worimi people here in Newcastle in the Hunter region, and to pay my respects to elders past, present and emerging, and to any Indigenous people who have joined us today as well. And just to recognise and respect their cultural heritage and beliefs and their continued connection to their land. So just very quickly, what I'm going to do is to tell you about a particular project that we have applied our impact framework to, and then just walk you very quickly through the methods. And instead of the full results, I'm going to just concentrate on one component because this is a health economic session, and that's on the return on investment piece we did for this, and then end with some reflections. So the program I'm actually talking about is the Medical Practice Assistance Program. So the need for this was actually that there was massive workforce recruitment, retention and training problems within the primary healthcare basically sector. And in the Hunter region in Brisbane, there was quite a few locations. They identified this as being a real issue for primary practice. Practice owners and managers found that it was difficult to find and train new staff to understand the general practice environment. And then many of them, after investment, would leave to find other jobs. In terms of the practice nurses in these environments, they really found that they wanted to spend more time in those higher level tasks and patient services, but they were constantly being burdened with some of those other tasks, and particularly administrative tasks, but also very low level clinical tasks for which they were significantly overqualified. And the receptionists and admin staff were concerned about being asked to perform some of these tasks for which they had no formal qualification. So based on this need and problem, they developed the Certificate 4 in Medical Practice Assisting. Now, this actually came out of Brisbane, out of the Brisbane PHN, but the project that I'm talking about is in the Hunter region. But they created this particular certificate to train receptionists and admin staff for them to actually work in general practice. So it was around advancing some of their administrative skills, but also to gain some clinical support skills so they could support the team. These MPAs work always under the supervision of a healthcare provider, so either a practice nurse or a GP. And it's a great pathway for them to a career as a healthcare practitioner. So we showed in this that quite a few of them actually went on to do a nursing degree. It was about an 18 to 24-month course, and it combines online learning with clinical face-to-face workshops, webinars, and then they have about 200 hours where they have to apply these practical skills in the workforce, in the workplace, and supervised by a practice nurse. This is actually run by UNE Partnerships, that's the University of New England. They have a registered training organization that runs this training. This is just to give you a very quick snapshot. I guess MPAs are closest to enrolled nurses, but the enrolled nurses, as you know, are created for a hospital environment. The MPAs are created for the general practice environment. So that just gives you a bit of a snapshot of some of the different skills that they have, that MPAs actually have. So just to give you some context of what I'm going to talk about today, this program commenced in 2018 in the Hunter, New England, Central Coast regions of New South Wales. So that's where we are in Newcastle, but going down into the Central Coast, closer to Sydney, and into the New England region, so up through Tamworth and Armidale. The PHN that covers this whole region provided scholarships and also promoted and provided administrative support for basically general practices to actually access this training that was provided through UNE Partnerships. In 2019 or 2020, when we came across this project, there had been no formal evaluation undertaken. There was some money through the MRFF that was funneled through New South Wales Regional Health Partners. Through the Embedded Economist program, we were able to actually team up a team that works, my team that works here at the Hunter Medical Research Institute, which is basically a mixture of health economists and impact specialists, with the PHN staff to undertake an impact assessment of the program. It was retrospective, meaning we were looking backwards to see what had happened. And the PHN staff that were involved, part of the program was also to upskill them in impact assessment methods, but they also provided valuable feedback and administrative support for this project. So we worked very much as one team. So in terms of the methods, I'm not sure if any of you have come across, but this is one of the things that has come out of the Hunter, and that's the framework to assess the impact from translational health research. Now, you will understand in this context, I'm not actually applying it to a traditionally to a health research piece. It's actually being applied to an implementation project within general practice. So for us, this was, I guess, the first chance to use it in a different context. FATE is actually the framework is based on 3 existing methods that had already existed, and 3 different lenses, I guess, to look at impact. The first is the payback methodology, and we use metrics there to look at benefit through different domains of benefit, such as knowledge generation, clinical care, policies and programs, the economy. This is probably one of the most used methods of impact assessment, where we have metrics that allow for benchmarking. The second of these methods is the narrative, which some of you might be familiar with. It's the one that's used in the UK REF system. It's where we talk about impact as a case study, as a narrative, and it provides that pathway from the need for the research all the way to how they got to the impacts. And I guess it presents some qualitative evidence for that translation and impact. So you're not just getting the results, you're actually getting that kind of pathway as well. But the third component of this is the bit that I'm going to focus on today, and that's the economic analysis. And what we do in FATE is we try and understand what the return on that investment is. So it's a research project, then what is the return on that research investment? In this case, it was trying to understand the investment in undertaking basically the MPA program within the region. This work is underpinned by a program logic model, which I'm not going to take you through today just because there's not a lot of time to do that. So in terms of what we did, because it was a retrospective piece of work, our data collection was very much around speaking to the people that were involved. So we did some red cap surveys with the GPs, the practice nurses, the practice managers, and the MPA students who were within those practices. And then we did some in-depth interviews with the MPA graduates. Those are the people who had gone through the program, and there was at that point 44 of them who were back in practice to really understand, what was happening. And then we also did some Zoom interviews with some relevant PHN staff who were actually liaison officers who are working within general practice, because they actually helped us understand what was going on the ground as well. Now, the results today are going to be very much focused, as I said, on the economics. So I'm really sorry, because there's a whole heap of metrics that I could have shared around, the impact it had for the GPs, the nurses, the actual MPAs, some of it around the patients that they were able to tell us about. And there's, of course, the lovely narrative in terms of how it's changed some of these people's lives, how it's changed the clinical setting, but I don't have time to do that. So I'm going to focus on the economic component of what we did. I did just want to quickly just mention one quick thing. In terms of practice change, I guess we understood that there were people that were doing certain skills, clinical skills, and doing some of these things without adequate training. But this is just a very quick snapshot of what the MPA graduates were performing in terms of clinical tasks since their graduation. So 100% were now measuring vital signs, complying with infection control and maintaining patient records. 91% were doing blood glucose, visual acuity, audiometry and spirometry testing, and supporting their CQI process and so forth. But just to give you a sense of basically this additional skill that's now available within those practices. In terms of the economic benefits, so all we had from the surveys and talking to them was basically that there was about 5 to 10% increase in billable items at the practice level, that practices were seeing between 5 to 12 extra patients per week, and practice nurses were seeing between 2 to 8 extra patients per week. So that's from the actual practice perspective. In terms of MPA graduates, it was interesting. There was for some an increase of about $150 to about $3 extra per hour, which equates to about $2,900 or $5,000, $6,000 per year. But 7 of them actually reported no increase in wages, and there was 22 that we interviewed. So a third of them actually there hadn't even been a change in wages. So it kind of alerted us to the fact that there was this program, but there really wasn't a lot done in terms of reintegration of these people. No one had really thought through what was going to happen when they came back. And of course, we had no real financial data on which to validate these claims. So, we had some information about what was potentially happening. And you overlay on that as well, that when we did a lot of this work, COVID had come to pass. And so the integration and reintegration of these MPAs was actually quite fraught, because the practice was no longer having people come through the doors as they used to. And so it really made it very difficult for us to kind of really get some good data. So there was no information on reintegration models per se. It was very hard for us to model what was really happening with practices when the MPAs returned based on the data that we had. There was no financial data. The other thing that we found out was that there was really no formal recognition of the MPA role at APRA. And so the value of it was not always clear to practice managers, practice nurses, and owners. So what we decided to do then was to model what could potentially be a potential reintegration options for practices, and actually then look at what the return on that could be for them. So the 3 perspectives we took was the PHN, and all we did there was just cost what it was for them to actually run this program. So it's really around a lot of the labor costs for the actual coordinator. And then the main item there was the scholarship cost, but it came out to about $2,880 per person that they put through the program. But unfortunately, there weren't really any PHN consequences that we were able to monetize because they were really interested in long-term retention, which we had no visibility to. They had only just come back into the practices. And so there was really not much we could do in terms of the consequences that they were most interested in. In terms of then the practices, we were able to microcost the actual cost of having a person go through that program. So we looked at student support and they did provide some fee assistance. But then economically, we also looked at what the MPA student training time was for the nurse that had to supervise it. They had to backfill some practice managers to actually take on the time when they were actually doing some of that practical stuff. And then there were 7 days of study leave that students got as well. We also looked at if they were to come back and actually do to utilize their clinical skills, they needed to actually be replaced because if they were sitting at reception, they couldn't do this work. So we actually modeled what it would cost for them to be replaced for half a day, for another receptionist to come in and for them to be able to use these additional skills. So as you can see there, the cost per student 12 months post-graduation was about $69,000 if you're looking at the economic cost. If you're just looking at the cash cost, it was a little bit less. Then what we tried to do here was to model some potential things that they could do if they actually had the MPA come back. So we know that basically if they could be released for that time, they could see between 6 and 12 extra patients a week. And so if you look at the potential annual gross revenue from that, just the extra patients per week, that's what we came up with, somewhere around the $12,000 a year. Then there was some tests such as health assessments and care planning that wasn't being done in a lot of these practices because they just didn't have the capability. The nurses just didn't have the time to do that. So if you could have an MPA that was actually releasing the nurse to work on these high order tasks, they could be doing all of these health assessments and GP management plans or team care plans for which there is, obviously revenue coming in for that. So if they were to do these at the, capacity, there was basically opportunity to create, resources of about $144,000 into those practices. We also looked at some tests that the actual MPAs could do as additional billable clinical tests. And all we did there was to do some modeling around if they were to do that in the 4 hours that they had, then, a reasonable number of tests per year. And of course, none of this is exact. You have to bespoke it to each different practice, but that just gave them a sense of where the additional income might come. We then looked at the MPA graduates and we costed what it was for them to go through the program. Again, it was basically the unpaid time. We costed at 35% of their wages, but also around the MPA leave that they took. There was the only cash cost for them really was, in terms of getting to those clinical sessions, some travel, parking and equipment as well. And for those that got remunerated sufficiently, if they got at least $1.50, they would then have a return of about $3,000 extra in their wage a year. And if they were paid the $3, which would take them up to an enrolled nurse's wage, then they got about $6,000. So basically, just to summarize, the economic cost is for the PHN was about $2,800. For GPs, it was about $70,000. And for the MPA graduates, it was about $3,000. And if you're looking at effective reintegration, within 12 months, we would expect that through increased productivity, that the actual practices would recoup their investment. And graduates as well, if they were paid appropriately for their skills, they would recoup that investment within 12 months. Just some very quick reflections. Obviously, it would be much better to have taken this prospectively, undertaken this piece of work so that the actual data could have been captured throughout. There was real blind spots in terms of not really understanding the impact on retention and on patient care and satisfaction because that was never set up. COVID, as I explained, really changed the way services were delivered. So it'd be lovely to go back and do that in a non-COVID environment and setting. And by doing this modeling to address the lack of data, the need that was voiced by the actual practices, we were able to help their cause. And I just wanted to quickly There was an MPA conference that I went to on Saturday that I presented on, and it was really interesting to see. Abby Anderson was one of the people that set up this program, and she was quoting the work that we had done, saying that it was time now to actually use this to get a dedicated recognition of the role, a dedicated award, and more importantly, to actually give them effective reintegration options, because there was never really much attention paid to that, and how they can manage this role within the team practice. So that was a good outcome from that. I've just got some resources there, and I'm going to end there to say, if you're interested in FATE, there's the paper there, but the MPA program work is also being published as the MPA paper, which you can have a look at. So thank you. I'm going to hand back to Sarah.
Yes, thank you very much, Shanthi, for that. That was really interesting to see how the FATE could be used in that situation. All right, so what I'm going to do now.
Has that gone back?
Yes, that has, thank you.
Margaret, if they turn out to be
okay, so now next we have Associate Professor Courtney Ryder. She's an early career researcher injury epidemiologist, Aboriginal academic and discipline lead for injury studies in the College of Medicine and Public Health. Her research is leading new ways of working with Indigenous data through knowledge interface methodology and Indigenous data sovereignty to change the deficit discourse surrounding Aboriginal and Torres Strait Islander health statistics, particularly in injury. She was awarded her PhD from UNSW in 2021. So now I'll stop sharing my screen and that'll be over to you, Courtney.
I'm assuming everyone can see my bright slide there. Thumbs up. Awesome. Excellent.
Thank you.
So I'm going to be talking to you guys today about something a little bit different, and that's the real impacts of healthcare costs in terms of remote Aboriginal communities. But firstly, I would like to start by acknowledging that I'm presenting on the lands of the Kaurna people and pay my respect to elders past, present and emerging. But I'd also like to acknowledge traditional lands that you might be zooming in from today as well, and also acknowledge other Aboriginal and Torres Strait Islander colleagues who might be listening today as well. So I'm going to be talking a lot about out-of-pocket healthcare expenditure today, or as we call them, OFFIEs. So OFFIEs in the context of what I will be talking about today are expenses related to health conditions that are not covered by universal taxpayer funded health insurance, such as Medicare or private healthcare insurance. So these expenses include direct costs such as gap payments, transportation, pharmaceutical costs, equipment purchases for the home, but they also include indirect costs as well. So this includes things such as carers taking time away from the labour force, as well as perhaps a patient or a parent, and also time away from, say, education or study. And this all results in a decrease in household income. So what got an injury epidemiologist into thinking about out-of-pocket healthcare expenditure? You might be wondering that. So this graph here, this shows some work that was from my PhD. And we found my PhD was focused on burns injuries in Aboriginal and Torres Strait Islander children. And in my research, which you can see from this Cox regression model here, we found that Aboriginal and Torres Strait Islander children had a median hospital length of stay 4 days longer than other Australian children. For this particular model, we were looking at prognostic factors, and they were quite similar between both groups, but length of stay was much elevated for Aboriginal and Torres Strait Islander children. But I'm not presenting on those results today. That's for another sort of discussion. But what we did consider in terms of this longer length of stay in hospital was the impact on Aboriginal and Torres Strait Islander families, certainly through inequity manifestations like out-of-pocket healthcare expenditure. And another reason for looking at this as well is that in Australia, there's a $30 billion economic burden from OFFIEs. So, and the last Senate inquiry in this area identified Aboriginal communities as one of the most vulnerable. Then there's also the amalgamation of unprecedented events, which hasn't assisted as well. And the media loves reporting on these impacts. So you've seen things such as the cost of living, labour force participation, food and housing security. And if anyone was on the ABC on Monday, you probably saw there was an article focused on tertiary students and then the reality of them having 2 jobs and having to eat 2-minute noodles once a day to pay for their rent. However, not much has been covered surrounding how patients are delaying or avoiding medical care and treatment, such as appointments, or not filling prescriptions because they can't afford their health care, especially Aboriginal families. And then the next reason for doing this as well is this quote that's actually up on the slide there. So this is a quote from one of our participants in Ceduna from our recent study. And here we have an image of the Royal Adelaide Hospital, and we have the nearby parklands at night time. Personally, I wouldn't want any of my family, especially if they are unwell or sick, having to sleep here. And we should never, ever expect any patient seeking medical treatment to have to do this. There are failures in the system if this is the option. So to start off with looking at out-of-pocket healthcare expenditure, we did a bit of a scoping review to think, well, what tools or measures are actually out there in Australia? And if anyone has done that, looking at OFFIs, everything points to this survey. This is a survey developed by Beverly Asu. However, this particular survey has been generated for the general population, and it also hasn't been psychometrically assessed in terms of its validation, so its validity and its reliability. So we don't know whether it's actually capturing concepts around out-of-pocket healthcare expenditure or not. So in my PhD, what we did is we decided to look at modifying and assessing this tool for Aboriginal and Torres Strait Islander families impacted by burns injuries. Firstly, to start off with, it's critical that you engage with end users. So we yarned up with Aboriginal families whose child had received treatment for serious burn injury across South Australia, New South Wales and Queensland, part of that face validity sort of process. And a range of themes were identified. So there was the cost for travel, the cost for pain medication, loss of employment, loss of social activities, and then themes around support such as family and services support. We found that financially, Aboriginal families were impacted because of out-of-pocket healthcare expenditure. But what we also found, though, was that economic hardship was reported in families, especially those residing rurally or with reduced employment capacity. And family and network connections were actually mitigating factors for this financial burden. So we took all of the different themes that we identified out of there, and we modified the ESU survey, and we decided, great, we'll pilot test this retest methodology over a 2-week period with 67 Aboriginal and Torres Strait Islander parents. And in an ideal world, this would have been perfect. The results would have come back glorious. It would have been fantastic. We would have had this new tool. But that wasn't the case. I feel it was a complete failure. My supervisors told me I was being a bit too dramatic. But what we did come up with in terms of the conclusion is that more work was actually needed in this area. And perhaps that modification of a tool for Aboriginal and Torres Strait Islander communities isn't appropriate, that it needs to actually be, designed from the ground up. So making sure that we took a very strength-based approach to that outcome, where failure is part of the process of success, we applied for seed funding to redo this project. We worked closely with the Far West Community Partnerships for this project, whose board of directors actually approved this project as their Aboriginal communities had identified OFFIs as a priority area. Now, the Far West Community Partnerships is actually located in Ceduna, and they do outreach to a whole range of different communities in the Far West, all the way up to Oak Valley, so like up to the WA border. Now, for this particular research project, Indigenous knowledges and methodologies were central to this. And really, this is because, a lot of our Western constructs dominate the OFFI literature and knowledge and experience in Australia. And so to reorientate this power imbalance and focus on the relationality of out-of-pocket healthcare expenditure for Aboriginal people in the far west of SA knowledge interface methodology was engaged with the research team. So in this study, we yarned up with 10 Aboriginal participants across a range of health conditions who'd actually travelled to Adelaide regularly for their care. And in terms of this image here, in terms of themes, we placed together some early themes. So the Aboriginal Research Fellow and myself, we came up with these early themes and drew them out. And this was really important to get early translation of information back on the project to community. So the Far West Community Partnership could use this image here on their Facebook page, in their newsletters and so forth to report on those early outcomes. But from there, we obviously had a lot of transcription, sort of like transcripts to go through. And we undertook a collaborative approach to thematic coding to identify themes. So transcripts were listened to. We listened to them because it's not enough just to read a transcript. You need to hear the tone of the voice, the pauses, be in that moment of what was actually being there. So we picked up things around that. Then we coded, and we'd have regular catch-ups going over our themes, where we then arrived at the current themes that you can see there. And there's the manuscript of these, there is a manuscript around these main themes, which is currently sitting with the Journal of Rural and Remote Health. So fingers crossed that gets published there and we'll have outcomes. Now, on the next couple of slides, I'm just going to highlight some of the themes a little bit further, and you can see some of the quotes there. Now, the cashless debit card, which is currently being scrapped, was actually in play when we were undertaking these yarning sessions. And you can see from that top quote there, that's actually showing an impact from the cashless debit card. PATS, which is the Patient Assisted Travel Scheme. So PATS is funding that any rural or remote patient can apply for, but you have to live 100 kilometres both ways away from a regional setting, and the specialist has to not be able to be visiting you. And you get a certain amount back in the dollar for petrol and about $40 for accommodation for that night, but it's only a couple of nights of accommodation. What we found here was that the reimbursement approach of PATS was not working, and that the system needed radical change to work effectively for Aboriginal, rural and remote families. Because what the option was at the end of the day for those families who were on either the cashless debit card or having to rely on PATS is they were left with little options. They had to sell assets, as you can see in that top quote. They were borrowing money off a family, or they were having to go for those quick and dirty sort of loans, those 2,000 quick loans. And cancellation was also common for appointments as well. And indirect costs were also evident in this data, which you can see in that last quote there, where a carer is having to take time away from work. Protective factors were also evident in the yarning sessions as well. So closing the gap, the Close the Gap initiative, where Aboriginal patients with a chronic condition can sign up for lowering payments for their medication. This assisted families and was really important. Family and community networks were also protective factors. And then there was the social, cultural and emotional determinants as well. Being able to practice and engage in culture to mitigate out-of-pocket healthcare expenditure was really important, which we can see from the bottom two quotes there. But then as well, there was the resilience of Aboriginal communities, which can be seen by that top quote there, but still the impact transgenerationally on individuals and communities as well. So obviously, we took these main themes to go through our psychometric sort of process. So we had the yarning sessions, and then we developed the items from there. Now, in terms of developing the items, we'd actually undertaken a scoping review on the design and development of surveys and patient-reported outcome measures with Aboriginal and Torres Strait Islander communities, which also helped to inform our work. We worked with a linguist in terms of that work. And I should have mentioned as well, in our yarning sessions, we received feedback as well around what good survey design looked like and how individuals like to answer questions and what kind of scales they liked as well. So we used all that information. We did a judgment quantification, and then we'll move into the taking the survey section. So in terms of our judgment quantification, we contacted 6 experts, and we had 5 participate in this 16-item survey. They undertook a 4-point scale where they rated each item as being highly relevant to not relevant. If it wasn't relevant, they also had to rate why it wasn't, or sort of discuss why it wasn't. Then we undertook an item content validity index across each of those items, and you can see the results there. So anything that 0.8 or above, we kept. 0.5 to 0.8, we modified. If it was below 0.5, we removed it. Based on feedback, we did actually remove one of the items, so we ended up with 15 items. And on this slide here, this just shows we're actually at the stage where we're about to release this survey to the community for test retest. So that's actually going to be occurring next week. And down the bottom here, we have an example of one of the part of the questions and the kind of item scale that we had. So, you know, we've got the different faces, and we also have this recorded as well, so people can listen and participate in the survey through listening to somebody speak it. These are the kind of thumbnail type images we're using on social media to actually advertise the survey, along with the sort of advertisement that we've got. And we're looking at a total of 40 participants, a test retest approach for it as well. And lastly, I guess to end with is kind of the future of where this could go as well. So in the future, it would be fantastic to have like almost a trip advisor, but an offie advisor, I guess you could say, in terms of providing community support for health and travel. So when families in rural and remote locations, especially Aboriginal and Torres Strait Islander families, are having to travel into town for care, they can seek support through an app that'll give them a whole range of different areas to help mitigate that. And that's the end of my presentation. Thank you for listening.
Great, thank you for that, Courtney. I think that was really interesting to hear about, and I think you can take for granted how easy it is for some people to access healthcare, and that clearly isn't the case for everyone. All right, and that brings us to our last speaker, which is Camille, and I will just share my screen. So Camille Schubert is a senior health economist at Adelaide University. She's primarily involved in modelling health outcomes and costs associated with proposals for new listings on the Medicare benefit scheme. This is for the Medical Services Advisory Committee and supervision of production of independent commentaries for the Pharmaceutical Benefits Advisory Committee on applications made by industry. Her primary expertise and interests are health economic policy associated with funding of health technologies, pharmacoeconomics, and economics of codependent health technologies. So let me just stop my sharing, and Camille, that's over to you. Thank you.
Thank you, Sarah. Okay, I'll just pull up my screen. Is that coming through to everyone?
Perfect. Yes, thank you.
And I'll just pay my respects also to the Kaurna people, their elders past and present, and acknowledge their cultural attachment to the land as well. So let's all right. So I was a little bit worried that my talk might be repeating everyone else's, but really it was fantastic to listen to the last two presentations, which are very, very different to the work that I do. The work that I do is very much more focused on health technologies like medicines or devices or diagnostics. So it's really complementary to have these different sorts of economic evaluations and see their impact. My talk's going to cover a few different areas. I'll just introduce the group that I work with and explain what we do and how. I'll walk through a case study, maybe two if we've got time, and just reflect on the way that health economics is fitting into translation and research and impact in this space that in. So first of all, who is ARTA, this research group that I work for, and what do we do and how do we do it? We are a contract research group. We're homed in the School of Public Health at Adelaide Uni within the Faculty of Health and Medicine. We are fully externally funded, so we rely on contract research. We're probably a little bit smaller than some of the other groups that have been involved in this webinar series. we've got about 25 research staff, mainly epidemiologists, health and medical scientists, about 7 health economists, some support staff, a computer scientist, an ethicist. So a bit of a mixed skills group. Who do we work for? First and foremost, our largest funding source or provider comes through government contracts that we have with the Commonwealth Government. So as Sarah said when she introduced us, sort of our bread and butter work is conducting evaluations for the Medicare benefit schedule, so for the Medical Services Advisory Committee, who make decisions about whether items are going to be listed on the MBS, and also for the Pharmaceutical Benefits Advisory Committee, who have the same role, making decisions about whether new medicines are going to get listed on the PBS for public reimbursement. We also do regular work for the TGA, the Therapeutic Goods Administration, who license new products and services, and less frequently, but still sort of steadily, we do work with the TARGI, the immunisation group, with the National Blood Authority, which is a joint state and Commonwealth government body. We've got some ongoing work with the Australian Genomics Health Alliance. We do work with Singapore quite regularly, and some internal work with the university here in Adelaide and the University of South Australia and the Basil Hetzel Research Institute here in South Australia as well. And then over the years, you can see some of the other sort of clients that have helped us with work and funding and contracts, other generally not-for-profit groups or government bodies as well. So that's who we work for and how we exist, really relying on that external work. So what do? We undertake evidence-based assessments of healthcare interventions, like I said, maybe diagnostics or medical services or pharmaceuticals, to inform policy and practice and help healthcare decision makers and policy makers decide whether they want or whether they're prepared to fund those items for the public generally. So our services involve epidemiological research, health economics, modelling and evaluation, ethics, and then increasingly sort of research support for integrated health technology analysis in research, which I'll come back to, guideline development and methodological research. So most of our research is what we call secondary research, in that we are not designing the studies. We are relying on studies that other people have undertaken and using the data that they've published, or in many cases it's not yet been published, but we've given access to this data to analyse it, synthesise it, and come up with our own interpretations and analyses of effectiveness, and construct health economic evaluations accordingly. So we often do sort of segregate the work into the two components of really establishing the clinical effectiveness and the clinical inputs that we need for our economic models, and then secondarily actually conducting the economic evaluation and the model. But really, look, those two functions, while we sort of step them out and share the work that way, it really is a team sport. And I just can't emphasize enough that health economics, a health economist on their own is really limited. It's really the work we do really relies on that interaction with people with clinical expertise and people with industry expertise, and the knowledge of the real life sort of scenarios that we're looking at and trying to analyse and provide economic answers to. So it really is a team sport. And typically, so going back to those most common tasks that we provide, the commentaries for the PBAC or the assessment reports for the MSAC, they're our sort of our everyday work, they sort of then inform the potential listings that come after that. So I guess that's a snapshot of most of the work that we do. And then, as I said before, just sometimes we get involved in primary research as well. But predominantly it's this secondary research for these decision-making bodies. So I think why we do economic research has been covered certainly in some of the previous webinars. You know, there's been talk about opportunity cost and shared funding and limited budgets. So I'm not going to talk about that again today, but I'll go straight into how we conduct these economic evaluations. So typically the economic evaluations for technology assessment use what we call a decision analytic approach. Can often be depicted in a decision tree. And the main aspect of that, I guess, is that these economic analyses are always comparative. So it's never just about sort of mapping out the economic consequences of a new decision on its own. It's always in the context that it's compared to an alternative choice of action. So whether that's just the status quo, which is the most common comparison, or whether it's perhaps a different alternative, the critical aspect is that the evaluation is always comparative. It's we've always got to do something. The framework that we typically use is one that's probably very familiar to other people that are involved in clinical research and evidence-based medicine. We start with that PICO framework where the population, the intervention, the comparator and the outcomes are clearly defined from the outset. And then with economics, obviously, we're also interested in resource use. And for our economic analysis, we always need to define the perspective. So whether we're talking about, you know, the perspective from the patient's point of view, the healthcare system, all of society, that's defined. And typically for our MSAC and PBAC reports, that perspective is a healthcare systems perspective. Secondarily, the time horizon. So an economic analysis in the sense of these health technology assessments, if we don't know whether we're weighing up costs and outcomes, you know, for 1 year, or whether we want to look and measure those costs and outcomes, you know, perhaps over a lifetime, it might be decades. And it's always really important to have that clarified in your economic evaluation. What's the relevant time horizon? Because if you've really only looked at a year, perhaps, and when you're going to have health benefits and costs accruing for many years, then you can really sell yourself short. So that's the sort of the basic framework and approach that we use for nearly all of our evaluations. With the MSAC and the PBAC, they quite often like a cost utility analysis where we have a cost presented for an outcome in terms of quality adjusted life years. I think some of the previous webinars have talked a little bit more about quality adjusted life years, but basically one QALY, you know, represents the equivalent of a year in perfect health. So MSAC and PBAC like to have their economic evaluations rolled out to where you can come up with an incremental cost effectiveness ratio and say that the intervention costs a certain amount of dollars, you know, per quality adjusted life year gained. In reality, that's not always feasible. It does require data and a bit of modelling, and so if that's not possible, it can still be just relevant to present results in terms of, you know, costs for another outcome. Perhaps life years saved, or hospitalizations avoided, or heart attacks avoided, cancers avoided. The critical feature is really that it's the outcome, the economic outcome is clinically relevant and relevant to the patient. So no one wants to pay for just a change in blood pressure or change in heart rate. It's got to take that outcome to a clinically relevant and meaningful health economic outcome. So to put our PICO framework into a decision tree sort of context or diagram, we have our clearly defined population that we start with. So we know that the group of people that we're looking at providing this intervention to and what their problem is. And then we are making a choice between new proposed intervention or the comparator, whatever that may be. So each of those choices, the intervention and the comparator, we spent a lot of time mapping out and working out exactly what happens after that point of intervention. So the clinical management that changes, the effects that has on patient outcomes and intermediate health states and final health states, the healthcare resources that are used immediately and downstream and as they progress through those subsequent health states and have health events or whatever's appropriate for the clinical scenario. So that intermediary sort of mapping of the patient journey and the healthcare system interactions occurs again for both the intervention and the comparator arm. And at the end of the day, we have total costs that we can sum up for our intervention and for our comparator. We have a total account of the health outcomes that are accrued over that journey as well for the intervention and the comparator. And we can put them together for our incremental cost effectiveness ratio. So once we've done that modelling, worked out the total cost, we can work out the cost difference and come up with this cost per quality adjusted life gained. And that's what the committees like to have on hand when they're making their assessment of whether something's cost effective or not. So I'll jump straight to a case study. So this is an economic evaluation that the group did a couple of years ago, probably about 3 years ago, I think. And the intervention that we were asked to look at was genomic testing for inheritable cardiac myopathies. The Royal College of Pathologists had approached the Medical Benefits Division and said that they would like funding considered for genetic testing of 22 genes for heritable cardiomyopathies that are associated with sudden death. Those conditions there's a number of sort of phenotypes or a number of clinical presentations of those conditions. They range in their severity and symptoms, but about 1/3 of cases are associated with a particular genetic variant. And if the cardiologist is aware of that variant, that might sort of refine their diagnosis or change it and inform the prognosis. In actual fact, in most cases, there isn't a change just on the basis of knowing the genetic variant, because the cardiologist is managing the patient based on their clinical presentation and their symptoms. But just occasionally, if they identify a variant that's really pathogenic, then the cardiologist might recommend an implantable cardiac defibrillator. So just occasionally, that's relevant. So you might sort of think about that information and think, well, it's just a simple one-off test. The condition is serious cardiac myopathies are pretty serious. They're lifelong. You know, potentially if it means that an implantable defibrillator is implanted in someone, you know, maybe that's going to save lives. So why wouldn't a test, you know, a simple one-off test be cost effective unless it's really, really expensive? But it all looks pretty reasonable. Obviously, we need a little bit more information. So we start digging, and it doesn't take long really for it to become apparent that it's actually less than 1% of patients where the genetic, you know, finding their genetic variant will change their management. And it really is, it's less than 1 in 500 where it actually might suggest, you know, the cardiologist might actually change their mind about whether a implantable defibrillator is worth it. So I sort of do concede that the numbers are looking fairly low in terms of what happens, the change in management that happens immediately from this test. Maybe it's cost effective, maybe not. Obviously, we need a lot more data as well. The test is about $1,200, we're told, so that's not insignificant. And if we're talking, you know, 500 odd cases, for that to change, then $500,000 or so or more is associated with just that decision to, you know, implant an extra defibrillator. So now we're sort of thinking, oh, how can we possibly sort of, even intuitively or off the cuff, back of the envelope, it's starting to get really hard to make an assessment of whether this test is likely to be cost effective without a proper analysis. And there is a lot more detail that we need to consider with the funding, because at this point, we've just looked at that immediate sort of first level of impact. But as I said, when we look at our decision tree, we need to go a lot further than just that immediate, straight immediate consequence of the intervention. We'll look to what happens further down the line and over time with the patient journey. And what we find with this test is that it's not so much the events in the patient themselves and the potential change of management there that can provide value. Because these conditions are heritable, then if a person is identified to carry an inherited genetic variation, their family members can also be tested, and it can be really informative for them as to whether or not they're affected by the condition. If they're identified, chances are it will be earlier than they would have otherwise, because you know, the reason they will be tested is because they haven't yet been symptomatic, and earlier treatment can certainly be very beneficial to them and even save their life. Also, it will be useful in downstream reproductive planning. If it's a dominant condition, they might want to utilise that genetic knowledge and make plans to minimise that being inherited by their children. And on the other side of the coin, if the family member actually is identified that they don't carry that inheritable gene, then they can stop worrying about that and stop being monitored in their life. So there's quite a significant impact to the family of the person that perhaps initially gets tested. So yeah, we've got different costs for the family testing, and we've got to take into account the surveillance costs and the monitoring of family members, and we have to get data on all of those probabilities of variants being identified, of family members being affected, and change in management happening. So we spend a few months going through all of the literature. We usually would have a team of 3 or 4 people working really hard for perhaps 3 or 4 months doing literature reviews and researching and putting together this contracted assessment report with an economic model to assist the MSAT with their decision. So in this case, we have our PICO parameters defined, our problem, our population, the intervention that we're proposing, which is this genetic testing, the comparator, which is no genetic testing, and we do our research on the pathways and what happens. Now these pictures, hopefully they're not too blurry, but we have to look at, like I said, so the comparator with no genetic testing in this particular specific type of cardiomyopathy. So we actually had to look at a number of different presentations of cardiomyopathy separately, but I'll just present the charts for the HCM group. So where they were suspicious that it was a heritable condition, the patient received their treatment, and it was recommended that relatives were monitored. Where we have genetic testing as an option, the patient will be tested. If a variant is identified, then they can be managed accordingly. So there might be that small change in management, but the key is that they would refer their biological relatives for testing as well, rather than just this ongoing monitoring. They can actually get tested, and it can be confirmed whether or not they've got the same condition or not. Likewise, we have to map out for the relatives. So without the genetic testing, it is just that repeated monitoring. With testing being available, if they accept that, they may find that they are carrying the condition, in which case they are managed sooner. Can also refer their relatives on, apply it to any reproductive planning decisions they might be making, or alternatively, like we said, if they're found negative, then they can be released, I guess, from future requirements associated with the condition. So these conditions and the pathways are mapped out, and the costs associated with those, and also the outcomes, the impacts for the patients themselves, are mapped out at each step and progression along those pathways. We have to consider translation issues, and when we use translation in this sense, we're talking the translation of the evidence that we have perhaps in the clinical trial to how that sort of is externally applicable, I guess, to the population, say, in Australia. And whether there's concerns of just assuming that what happens in our clinical trial and our research evidence, whether there's concerns about whether that will actually occur or translate into real life. So one of the issues in this case was that the evidence was very weak, so whether it would actually be seen in real life was uncertain. And then we also had a translation issue in that none of the clinical trials directly measured quality of life and estimated utilities, which is what we needed for our economic and evaluation to come up with a cost per QALY. So some modelling is involved there. The evidence is collated. The model was designed, and I won't go into sort of the hows and wheres and the justifications and the detail for that, but we put together this economic model. We can use some specialised software for that, as long as we've got all our inputs, which our epidemiologists and scientists have researched and put into their systematic review, and any other inputs that we've needed to identify for our model, create this model, and produce some outcomes and estimates for the MSAC. So in this case, we presented a stepped approach. In the first instance, when we just looked at costing, the difference in costs of having a test and testing relatives that were relevant cost about an extra $1,636 per initial patient that initiated having genetic testing. And given that only about 1 in 3 of the initial patients found a variant, and then depending on the number of relatives they had and the average number of variants there, the test cost about over $290,000 for every actionable variant that it actually revealed sort of in that first step. So $2,000 to identify a variant for a variant that actually, where it was going to change the cardiologist's management of that patient, over $290,000. So if our model had just stopped there, you would be questioning the cost effectiveness. But if we start looking at those lifetime monitoring costs and the fact that some of those relatives can be free of that, that dramatically changes the cost difference between implementing this test or not. And it comes down to just a difference of $243 between the pathways where testing is included or not. And that reduces our cost effectiveness ratio to just $43,000. We don't want to stop there either, because as we said, there's this potential for change in management and the implantable cardiac defibrillators to prevent sudden cardiac events and deaths. So let's consider those in our pathway as well. They actually have an additional cost. Obviously, planting the defibrillator involves extra costs, and our cost difference increases to $458. But now we actually have an estimate too of the number of events that we might avoid. And if we work out our cost per sudden cardiac death avoided, because we've implanted defibrillators in a small number of these patients, we've got a cost per death avoided of $562,000. It's looking sort of, I guess, quite interesting, perhaps promising, but for MSAC and PBAC, like I said, their preference so that they can sort of make these decisions about what's reasonable compared to other medications or services that might not be avoiding death, but might be helping quality of life or doing other things. The preference is that we go all the way to translate that into a cost per quality gain. And in this case, when we applied the time in the different health states with the different quality of life associated with those health states, we ended up with a cost per quality of $67,000 per quality adjusted life year gained. And in MSAC terms, or PAC, that number's not particularly unusual at all. That's pretty standard and generally considered not too bad in terms of cost effectiveness. So the research impact there...
Sorry, excuse me, Camille. We're just a little bit over time now. If you wouldn't mind wrapping up in the next couple of minutes, that would be great. Thank you.
No worries. Sorry. Yep. So the impact there is that genetic test got listed on the MBS, and it got listed midway through last year, and patients are already starting to have that test. And so I guess that's the translation. I certainly won't go through the next example. But over the last few years, we've looked at a number of interventions, many of them getting listed on the MBS and made available to patients. So the last thing that I was going to sort of talk about or reflect on was that, you know, traditionally the sort of health economics used to come through, we used to have our research and then our sort of translation and look at funding and guidelines, you know, in a sequential process, and health economics was very much just fitting here in the funding line. Now I feel like that sequential process is really often takes years. Patients are keen to get access to interventions and medicine sooner. Obviously, industries anxious or keen to get their interventions out sooner, and that sort of sequential process has now been turned into something of we have parallel processes, we have working together with our regulatory agencies and our funding bodies, where we don't always have the evidence initially for the funding body to be happy. We have these new schemes of coverage with evidence development where medications or devices might be sort of moved out and made available to the public while we keep collecting evidence about costs and effects, and funding bodies make their decision. So that whole research and translation it's really all become a much more integrated, I guess, approach. And economic evaluation, instead of just fitting with this funding body, is now increasingly being incorporated into the trials, and then also after funding or after items that are out there with use, collecting new evidence and re-evaluating and redoing evaluations. So it's perhaps become a little bit harder, I guess, I won't go through this, or it's become less sort of clear as to what the best approach always is with economic research and economic evaluation, but there are lots more options, and we're really finding, that earlier inclusion of economic evaluation can just aid that transition from the research stage to a faster translation and impact. I'll finish up there because I did waffle on, but any questions? And apologies that went a bit over time.
Thank you, Camille. No problem about going over time, but I think we are out of time for questions, unfortunately. But thank you so much to our three speakers for presenting today. That was all really interesting. And Camille, it was great to hear a practical application of how economic assessment could be done. So thank you for that. I just want to very quickly just point out our next Spotlight series, which will be happening in June. And this is on patient-reported measures. And I'm happy to be co-presenting that with, or co-hosting with the Commission on Excellence and Innovation in Health. And so that's it for today. I'd like to thank everyone for coming along and to our great three presenters again. So thank you very much.